First, by way of background, we know that light focuses in the front part of the eye and then focuses to the back part of the eye where it falls on the retina. The retina has two types of photoreceptors, rods, responsible for peripheral vision and night vision, and cones, responsible for color vision, daytime vision, and central visual acuity. The rods dominate the retina. There are about 120 million rods in the retina. And there are only about 6 million cones in the retina. But of course, the cones are critical because they're concentrated in the fovea, and that's where we have our central vision, where we have the visual acuity, the vision we think about when we walk around day by day. Inherited retinal diseases are typically due to mutations in genes responsible for photoreceptor integrity or the support structures for the photoreceptors. So here's a schematic of the eye, and you can see the retina can be thought of a three neuron circuit: photoreceptor, bipolar cell, ganglion cell, and then going through the optic nerve to the brain. And the photoreceptors are supported by many other cells, such as the retinal pigment epithelium, amacrine cells. We don't need to go into those details, Mueller cells. Mutations in genes responsible for any of these structures or functions can lead to inherited retinal disease. Of course, the fovea is a very special place in the retina. The inner retina moves aside and it's very cone dense, all cones, no rods in the fovea. Although the fovea is very cone dense, actually most of the 6 million cones in the fovea are outside of the fovea. And again, the retina is a rod-dominated structure, about 20 times more rods than cones in the retina. This is a diagram that I like, a graph that I like that shows how at point zero, which is the fovea, it's all cones. But as you go out, there are still cones in the periphery. And in fact, again, the total number of cones in the periphery is more than the total number of cones in the fovea. At about 20 degrees from the fovea, that's where rods peak. And again, the retina is a rod-rich structure dominated by rods. This is a nice electron micrograph that shows a section of peripheral retina illustrating that point. Those squiggly yellow lines are the rods. And you can see the retina is really a sea of rods. And every now and then here you see that plump structure colored in green. That's a cone interspaced among the sea of rods. Of course, the fovea would be different. The fovea is all cones. The purple represents the retina pigment epithelium. Again, IRDs can occur from mutations in genes or that are responsible for structure or function of the photoreceptors of the retina. Most of the IRDs that we deal with are from mutations in genes that affect the photoreceptor, but it could be in supporting structures also. It also could be in systems that provide nutrition to the retina. So there's really a broad category of diseases that can result in IRDs. That is a broad category of disease mutation. Now, what about phenotypes? What do we mean by phenotype? Phenotype means the symptoms of the patient, the history of the patient, and the findings that we have. And I really can't stress enough how important the history is. History really leads us to the diagnosis in the majority of cases. We want to understand the onset of the visual problem. Is it progressive? Is it stationary? Was it congenital? Did it happen recently? Is it mostly a problem in daytime? Is it mostly a problem in nighttime? Are the problems going from night to dark or from dark to light? All of these factors really help us hone in on if we were dealing with a cone problem, a rod problem, cone rod, rod cone, or mixed. The cone problems and cone rod problems, typically the patients have photophobia and poor central vision, poor color vision. Rod cone problems, patients typically have poor dark adaptation, poor peripheral vision, and the central vision is preserved until later. Stationary conditions, of course, are non-progressive. History is so important, and some of the questions that sometimes get neglected that are very important are medication history, because some medications can cause toxicity to the retina, the classic one being hydrochloroquine. There are others as well, especially with these newer anti-cancer agents. We really need a good medical history in all our patients. Also, be aware of associated disease because, as I alluded to before, because the retina is so sensitive, a variety of metabolic processes and systemic diseases can lead to retinal dystrophy. And particularly in children, we want to be careful about this because sometimes inherited retinal disease in a child is the first sign of systemic disease, and picking it up early is very helpful in anticipatory management and minimizing morbidity. A classic example is something like Bardet-Biedl syndrome, which we see commonly in the Middle East region. Another very important point is refraction. I mean, refraction is often the thing that helps these patients the most, and really we can have fantastic improvements from refractions. We can't just discount these patients because they have a retinal problem. Refraction is not only helpful in management, it also helps in diagnosis because patients who are highly hyperopic, the diagnosis goes one way. Patients who are highly myopic, that points to a diagnosis in a different direction. We take all of these phenotypic features together to make the diagnosis. Now, when we look at the retina, we want to look at the phenotype. Is it mostly the center, the fovea that's affected, and the periphery looks okay? Does the periphery look affected and the center looks okay? We want to characterize where anatomically the abnormality is. Typically, the abnormality is associated with modeling and often pigmentary change because the retina responds to death and disease of photoreceptors by pigment migration from the retinal pigment epithelium. So here's a classic picture of a right eye with classic what are called bone spicules. It's basically a pigmentary retinopathy. The center is relatively okay. There's a little dark spot there, but that's a shadow. That's an artifact. So, that's the periphery being more affected. That's classic for rod cone dystrophy or retinitis pigmentosa, where the periphery is affected first and it progresses, comes to the center. As opposed to this patient who has a maculopathy there, the macula is discolored and the rest of the retina looks pretty okay. Also, important to comment on the vessels. The vessels in the picture I'm showing you now look normal. In the top picture, they're thin and attenuated. This also gives you a clue whether you're dealing with global retinal dysfunction or localized. So you have a maculopathy here in the second picture. It could be just the maculopathy, just the macular dystrophy, but it could also be panretinal degeneration. The only way to know that is by doing electrophysiology. We're looking at structure here, but function is a different thing. Certainly the structure of the fovea of the macula looks abnormal here, and the structure of the peripheral retina looks okay, but we don't know the function unless we do electrophysiology. And here's a patient where the retina actually looks pretty normal, but actually this patient has a disease. This patient has congenital stationary night blindness, and the symptoms lead you to that diagnosis. He has no night vision. Just because the retina looks normal, it doesn't mean that it's functioning normally. Electrophysiology is very useful in inherited retinal disease, but it's more useful when we're not sure what's going on. For example, in the bottom picture where the patient is complaining, but everything looks normal, that's a very good indication for electrophysiology. The top picture, though, where the patient is complaining and we grossly see there's lots of retinal loss, electrophysiology is not as useful. So not every patient with inherited retinal disease needs electrophysiology. I mentioned before, children are a very special situation because inherited retinal dystrophy can be the sign of something more global, like a ciliopathy or a mitochondrial disease. Most of them are isolated to the eye, but we always have to keep this in the back of our minds. This child here has no visual behavior. He's poking his eyes all the time, causing a sunken-in appearance, so-called oculodigital sign. When we look at his retina, actually, it looks normal, but he's very, very highly hyperopic. This is classic Leber congenital amaurosis, and if we do an electroretinogram on him, it's non-recordable. Two major classes of diseases we have to consider in children who come with early onset retinal dystrophy are ciliopathy, and Bardet-Biedl syndrome is the prototypical one. We're worried about these conditions because sometimes they come in with the retinal disease, but later on they go on to have renal failure. And we can pick that up early if we're suspicious about it and alert the proper specialists. Other classes of disease we see are, mitochondrial disease, lysosomal storage disease, peroxisomal disease. I don't think you need to know the specifics, but you should keep in mind that a child who comes in with an inherited retinal disease, be suspicious, refer to someone who can evaluate, if you don't feel comfortable yourself, whether or not this is the first sign of systemic disease. Multimodal imaging is fantastic. I can't imagine looking at a patient with inherited retinal disease without multimodal imaging. But multimodal imaging only gives us information about structure. And there's only one test that gives us information about function. I alluded to it before. Of course, it's the ERG. I'm not going to go into details of ERG. We don't need to do ERG on all patients with inherited retinal disease. It's more if we're not sure what's going on where ERG comes in handy, and that's a topic for a different talk. Now, what do we mean by genotypes when we're talking about inherited retinal disease? Well, inherited retinal disease is typically from gene mutation, typically autosomal recessive, can be autosomal dominant, can be X-linked, can be mitochondrial. There are hundreds of different genes that, when mutated, can lead to inherited retinal disease. And it's quite overwhelming. And beyond the scope of this talk, to talk about genetic testing, let me just say that what we need to do is to get as detailed a phenotype as possible. That's our job as an ophthalmologist. Do we think this is retinitis pigmentosa, rod cone dystrophy? Do we think it's cone rod dystrophy? Do we think it's macular dystrophy? And then get directed genetic testing to try to support or refute that hypothesis. Because genetic testing is its own can of worms and leads to all sorts of unexpected findings if it's just done on a broad manner without proper interpretation. It's very useful to work with a genetic counselor, geneticist in interpreting genetic testing. This is just showing how the number of retinal dystrophy genes has exploded over the years. Genetic testing is tricky, and I'm just going to sit and give you a few points about it. Even if you have a negative genetic test, it doesn't mean that the patient does not have a gene mutation, because genetic testing methods are not perfect, and each type has its own advantages and disadvantages. A positive genetic test doesn't necessarily mean the patient has a mutation in that gene, because sometimes there are false positives. The bottom line is genetic testing should be ordered by or in concert with someone who understands these pitfalls. It's not like ordering a CBC. It's not like ordering, a fundus autofluorescence. Genetic testing is a bit complicated in understanding, and it's a whole subspecialty in of itself. We don't have to talk about this. I think everyone knows about autosomal dominant, autosomal recessive inheritance. X-linked inheritance is important, because it's very underdiagnosed because people don't think about it. In classic X-linked disease, the boys are affected and the females are asymptomatic carriers. Actually, up to 20% of boys with inherited retinal disease in some series have X-linked disease, but it's often not picked up because it's not thought about. And a very useful thing to do if you suspect X-linked disease in a boy is to look at the mothers, because very often it's inherited and very often there are female carrier signs. For example, here's the mother of a boy with X-linked albinism, and there's some peripheral modeling, which is the classic carrier sign for X-linked albinism. Another under-recognized inheritance pattern is mitochondrial disease. And, we have to think about this when we have other things going on, such as, limitation of extraocular movement or ptosis. Mitochondrial disease is something that can occur also. Some patients with retinal dystrophy and diabetes also have mitochondrial disease.